Hi, my name is Bradley Hancock, and I'm here with you today to share a gallium PSMA PET case study that highlights the importance of recognizing halo artifacts. This case outlines the importance of reviewing images. As technologists with busy patient loads, it is easy to get distracted and omit this vital step before dismissing our patients. Being at the front line in nuclear medicine means our diligence impacts the quality of care our patients receive, which can have important implications for the patient's future management. So in this case, a 67-year-old male with a history of prostate cancer presented to MARTA Imaging PET Department for a PSMA PET scan. The patient was first diagnosed in 2017 and treated with radiation therapy to the prostate bed. The patient's PSA had risen from 0.27 to 2.0 in a 12-month period, and as such they were referred for this test to evaluate the potential disease recurrence. A CT of the chest, abdomen and pelvis was also requested and performed concurrently. The patient was administered with 170.5 megabecquerels of gallium-68 PSMA and scanned post-void after a 45-minute uptake time. A CT of the chest, abdomen and pelvis was performed first, followed by the PET, then an additional low-dose CT for attenuation correction. The CT-AC is performed last to allow better differentiation of the bladder from the prostate, as the iodine contrast will collect in the bladder during the PET acquisition. The patient unfortunately could not be scanned with arms up due to an underlying shoulder pathology. As you can see from the initial acquisition, there is normal physiological uptake of tracers, save for a small node anterior to the L5-S1 junction just to the left of midline. There is also a marked decrease in counts in a band-like distribution surrounding the bladder, just here. To ensure the images were of diagnostic quality, the patient was asked to void and a repeat scan was acquired. The repeat study showed uniform background counts throughout the pelvis, a complete resolution of this artifact. Surprisingly, the second scan also revealed an additional 3 PSMA-avid lymph nodes superior to the bladder that were not visualized on the initial images. The avid node anterior to L5-S1 was again seen, thus a total of 4 PSMA-avid lymph nodes, indicated by the green arrows, were now demonstrated. Correlation with low-dose CT enabled precision anatomical localization of these nodes. If the repeat study had not been performed, the extent of the patient's recurrent prostate cancer would have been underestimated and treatment planning may have varied dramatically. So, how can the difference between these two scans be explained? The cause of this image appearance is known as a halo artifact. It can be defined as a photopenic region surrounding structures with high tracer uptake or a high organ-to-background ratio. This reduction in counts is caused by an error within the scatter correction process where data is incorrectly lumped with the areas of high activity. In the case of the PSMA PET study, it is most commonly the bladder and the kidneys. Other causes of halo artifacts can be any tissued or arterialized doses, or any other PET imaging technique that involves areas with high OBRs. This artifact can have significant implications for PSMA PET studies in particular, as about half of positive PSMA PET scans contain disease spread to the pelvic lymph nodes, just like this patient. When imaging regions of such significant prevalence for disease recurrence, the images we acquire need to be as sensitive as possible to reduce the likelihood of a false negative. In order to reduce the effect of halo artifacts in PSMA scans, we essentially need to dilute the concentration of counts in the bladder. We can do this in a number of ways, such as by keeping the patient hydrated, ensuring the bladder is voided as much as possible before scanning, and in some cases giving IV diuretics to encourage micturition. An additional option may be the use of urinary catheterization. However, this is subject to availability of resources, and unfortunately in patients with enlarged prostates, such as this case, there are additional inherent safety that may make this not a viable option. Unfortunately, given that we are working with patients with enlarged prostates who likely already experience some degree of urinary incontinence, all of these solutions create a host of logistic issues when it comes to actually performing the scan. The main takeaway, however, is to always check the images before dismissing the patient. If a quick 8 to 10 minute scan will save the patient either a misdiagnosis, a delay in treatment, it is always worthwhile to do so. Here is a quick comparison of the first PET acquisition on the left and the second on the right. The banding effect caused by the halo artifact is clearly resolved in the second image, and as such we can assume the second image to be a much more accurate representation of the PSMA distribution in this patient. It is also important to consider the accuracy of SUV values for these two scans. The one node that was detectable in the first scan more than doubled in SUV max between the two acquisitions. Additionally, the other 3 nodes with significant uptake cannot be visualized in the first picture, as counts are not significant enough to differentiate from background, whereas they may be detected and quantitatively assessed in the second acquisition. Differences in level of detection of disease caused by artifacts can have considerable impacts on our patients. It is imperative we perform appropriate quality assurance on all images we acquire. Adequate QA means significant reduction in avoidable false negatives for our patients. In this case, the impact of accurate SUV values cannot be understated. As the repeat images were considerably more accurate, they will be a much better source of quantitative comparison for monitoring the disease throughout this patient's future management. Inaccurate results may also lead to inappropriate selection of treatment method. In this patient's case, the management team planned to treat the affected nodes with a combined approach of radiation therapy and hormone therapy. Had all 4 nodes not been visualized, it would likely mean an ill-curated approach to treating this patient's disease. Just a couple of key takeaways from this case. It is important to remember that technologists are the first line of defense for our patients while they are in our department. It is important to understand the images we are acquiring and when things aren't quite right, so we may best advocate for our patients' health. It is our job to ensure that they receive the most appropriate care they can through the service we provide, and as such, recognizing potential management-altering artifacts is an essential part of our work. Thank you for listening, and I hope you learnt something as I did.